sensory function, as I was saying in the last one, again, a lot of this, the types of sensory receptors, the sensory pathways, those are all covered in a much greater detail in the spinal anatomy section. So I'm not going to re-go over them all here because, again, the physiology and spinal anatomy, they're tested in the same block. So we're not going to spend more time going over the same material. Proprioception, again, we'll see that just a little bit down below when we talk about skeletal muscle. Receptor physiology, talking about receptor potential versus the action potential. A lot of this I don't want to go too deep into. I've included it in here because this is something that's included in the components of the board material, but especially in the last couple of years, I have not seen any questions kind of pop up from this specific type of material. So again, if you want to come back and read this chart, you can. I wouldn't worry too much about it though. These components do pop up every now and then a little bit more on boards when we talk about adaptation of receptors. So receptors adapt over time and depending on how frequently they're used, if they're used excessively or not enough. So adaptation is referring to a decreased response of a receptor to a constant stimulus over time. Certain receptors are going to adapt very quickly. Others adapt very, very slowly or tonically. So the adaptation of receptors, this is something like, for example, when you first get married and you start wearing a wedding ring, and the very beginning when you start to have it on, it really kind of, you notice that it's there more and more. Like when you first start wearing a watch, you notice that it's there. And then after a certain period of time, after you've been wearing it for a couple of days consistently, as soon as you take it off, then all of a sudden you notice like, oh, that feels weird not having it. Those are example of adaptation of the different receptors. Phasic receptors, these are ones, they respond strongly at first when a stimulus is applied, but they stop firing or reduce response dramatically even if the stimulus continues. So these are the ones that they stop responding really fairly quickly. So these are ones like the Pacinian corpuscles, the Meissner's corpuscles, or hair follicle receptors. These are for very quick, short stimuli. We call them the phasic receptors. Tonic receptors, these continue to respond throughout the duration of a stimulus. They're good for monitoring constant conditions such as pain or body position. So a big one is our nociceptors. So think about nociceptors. Like our body doesn't care if we're wearing a watch, like our hair follicle receptors, if we're wearing a watch, that's not a bad stimulus and your body's gonna, okay, we can rule that out, we can ignore it, that's fine. But let's say we step on a nail and now there's a nail stuck in our foot. Our body's gonna want to continue to let us know, hey, this is an issue until we do something about it, because that is going to continue to be dangerous to us. Or in this sense of like muscle spindles, we want to know proprioceptively where our body position is at all times to assist with proper postural movement as well as balance and that sort of stuff. Pain physiology. Pain physiology pops up a little bit more in parts 2 and part 3, kind of like in the chiropractic philosophy chunk of material. But you will get bits and pieces of it in part 1. So talking about the pain receptors, aka nociceptors, they're also called free nerve endings or naked nerve endings or free naked nerve endings, all of that kind of stuff. But these are located throughout the body in the skin, the joints, the muscles, and the viscera. They can be activated by mechanical stress, thermal stress, or even chemicals as well. Each of these, we think a lot of these, pressure and stretch, hot and cold, bradykinin, prostaglandin, histamine, these are all, our pain components. Whenever we talk about pain and temperature, make sure that we link it to what's called the spinothalamic tract, also known as the anterolateral system. That's just a memorizy thing. Our pain goes through the spinothalamic tract. There are two types of fibers when we talk about pain. 90% of the time, they're going to talk about C fibers. Okay, if they ask anything about painful stimuli, most of the time they're talking about C fibers. Okay. If C fibers is not an answer and it's asking you about pain, A delta fibers is our next best answer. Almost exclusively when we talk about pain, they mention C fibers, but like I said, A delta fibers is a really, really strong number 2 answer. Referred pain, this is a little bit more related to kind of the clinical pathology section, but it does pop up occasionally through general anatomy, spinal anatomy, and as well as the physiology stuff. We talk about referred pain or referral patterns. It's very heavily tested on boards parts 2, 3, and 4. So for sure we want to remember this. Referred pain is caused by when afferent fibers all meet together, especially from like when they meet from visceral, from organs, and from skeletal muscle, they kind of join and mix together. You almost get a little bit of what I would call bleed over or carryover of the signal, and your body can kind of confuse or mix those signals together. So this is why, for example, when we have gallbladder issues, the visceral fibers, the visceral nerves from the gallbladder end up meeting with and kind of conjoining with the same nerves that innervate the right shoulder, specifically that inferior medial border of the scapula. The pancreas, the spine at T10 level, the epigastric region, feels like you're being stabbed straight through there. The heart, you get the left shoulder, down the left arm, occasionally the left jaw as well for a heart attack. Intestines around the periumbilical region, appendix, early appendicitis in the epigastric region, later on the right lower quadrant again because the mixing of the visceral and somatic fibers. The kidney from the flank and from the back and radiates to the groin. The ureter radiates to the groin, and the bladder, the suprapubic area. These get heavily tested in all the boards. You'll see them, probably a couple of them on part 1, part 2, part 3, and part 4. When one of these will be one of your patients in part 4. Finally, the gate control theory of pain. Again, this is more tested on parts 2 and 3 and PT, but every now and again it pops up on part 1 as well. This was proposed by two guys, Melzack and Wall. Those names are important. We want to remember those names. This is referring to how non-painful stimuli can close the gate to painful input. Gate control theory of pain is where we get the TENS unit from, or if you ever have worked in an office where you use the interferential therapy. Obviously it has other benefits, dealing with inflammation and stuff, but it's pain nullifying abilities because essentially it inputs a bunch of an excessive amount of non-painful stimuli, which basically covers up and blocks the painful stimuli. This is the same logic as why if you, let's say you bonk your head on something, you hit your head on the corner of a cabinet, why when you rub it, it makes it feel better, because a non-painful stimulus, such as touch or pressure, can send signal to the brain faster than the slower pain fibers and help to prevent or to decrease the amount of overall pain that you feel. Okay, they'll nice and short on this one. Next chunk, we will talk about the autonomic function.